Okay, good morning everyone. Happy Friday. Thank you for wishing me back. Happy Friday, appreciate it. So today we'll do part 2 of the cardiovascular system. And if you're wondering when the exam 2 results will be released, I think 1 p.m. is a good idea so that we are all listening to the lecture. Because I personally think what we're going to talk about in the cardiovascular system is actually kind of complicated, right? So I would give you that heads up, and so please focus. And yeah, it's not many slides, very few slides, so you can go quite slow. Right? So the things which aren't clear, I'm happy to elaborate. Okay. So here's an overview of what we'll discuss. We're going to start with describing what the conduction system of the heart is. So yesterday we stopped by talking about 2 types of cells in the heart. We talked about the autorhythmic cells, and which are the electrical cells, and also the contractile cells, which are able to contract in response to the electrical signals. And so the conduction system will tell you how those autorhythmic cells are going to be organized, and how, because of the organization, the contractile cells can respond and the heart can pump in unison. The atria can pump in unison, and then following that, the ventricles can pump in unison. And then we'll see why these autorhythmic cells are capable of spontaneously generating an action potential by going through this graph here. We'll see why they are, what is so unique about these autorhythmic cells that they can spontaneously generate an action potential. And then we'll move on to talking about the electrocardiogram and how we measure the electrical activity of the heart. And I'll give you a couple of examples to tell you how any problems in the conduction system can be detected by looking at the electrocardiogram. And this is just for the sake of your interest. I won't get into the details of pathology and detecting that using electrocardiogram, because it's way beyond the scope of our discussion. So we'll just look at a few examples. And we will spend quite a bit of time talking about this figure here, the cardiac cycle. And in this cardiac cycle figure, there are 3 parts, right? On the topmost panel, you have the ECG, the electrical activity of the heart. Second panel, you have changes in pressure, right? This could be changes in the aortic pressure, the pressure of the blood vessel carrying blood out of the heart. You could have changes in the atrial pressure, and also changes in the ventricular pressure. So this second panel in the cardiac cycle is what I think is the most challenging, right? So I'll give you a couple of hints on how to remember that. And the third panel is changes in volume of blood in the ventricle. So as the pressure changes, the volume will change in a corresponding manner, and that is the third panel. And finally, we will move on to a concept known as the pressure-volume loop. And in this, we are describing pressure on the y-axis and volume on the x-axis. So in this picture on the right side, you see that the pressure is shown on one panel and the volume is shown on the panel below. And the PV loop is just trying to show the pressure and the volume in one graph. And they would use this clinically to see what is going on. So with that introduction, let's get into what is the conduction system of the heart. So you'll notice that the autorhythmic cells, they're going to be arranged in clusters known as nodes. And here's the first node, we have the sinoatrial node, SA node, that's how we abbreviate it. And we also have another node known as the atrioventricular node. So the AV node is going to be found in the junction between the atria and the ventricles. And these nodes will be connected by internodal pathways as shown here. So the conduction system of the heart is shown in purple. That's how we have it's been highlighted. And these AV nodes, they're going to give rise to an AV bundle, atrioventricular bundle. You would also hear this bundle described as the bundle of His. And then this would branch off, and you have a couple of bundle branches. And then this is going to further branch into the Purkinje fibers. And these Purkinje fibers will bring electrical signals to the walls of the ventricle. So this is the conduction system, and you will find the autorhythmic cells expressed in these nodes and in the internodal region. Now the question is, why are these autorhythmic cells capable of generating their own action potential? And the answer lies in these HCN channels. So HCN channels, H stands for hyperpolarization, C stands for cyclic, and N stands for nucleotide. So it is hyperpolarization of the membrane potential and the presence of these cyclic nucleotides which will activate these voltage-gated channels. And notice that they are called as the sodium coming in through these HCN channels is called as the funny current. And the reason they call it the funny current is earlier when scientists discovered this, they were surprised to find that hyperpolarization was able to actually open voltage-gated channels. Because until this point, when we discussed the nervous system, it was only the depolarization, the inside of the membrane becoming less negative, which would open voltage-gated channels. But in this case, we see that the inside of the membrane becoming more negative is going to open these sodium channels. So yeah, as you see here, it's activated by hyperpolarization and cyclic AMP. So the details on the number of cyclic AMP binding sites, there are 4 of them. The more cyclic AMP binds, and it will cause these channels to open. Those are details I really don't want to get into, but I do want to mention what C and N stand for, so that you know what the full form of the name HCN channels stand for. Are we clear on that? Okay, so let's look at the pacemaker action potential. So this is the action potential which is generated by the autorhythmic cells. Shown here on the y-axis, we see the membrane potential, and on the x-axis we have the time shown, so we see how the membrane potential changes in respect to time. So I want to draw your attention to this part of the action potential. Notice that it is gradually, the membrane potential, it's gradually increasing due to sodium influx. So the reason there is sodium influx is that previously there has been a hyperpolarization, and that is causing these voltage-gated sodium channels to open, and that's why there is gradual sodium influx. And the sodium influx will eventually cause a threshold to be reached. And when this threshold is reached, we will have the opening of voltage-gated calcium channels. Right? So that is the unique thing in these autorhythmic cells. So there is voltage-gated calcium channels which open, and so there is rapid influx of calcium causing quick depolarization, and at around 20 millivolts there will be voltage-gated potassium channels which open, causing potassium efflux. And it is this potassium efflux which causes this hyperpolarization, thereby opening the HCN channels, and again this cycle is going to continue. Does that make sense? Alright, so just to repeat what I said, we see that the resting potential is going to be unstable, right? And this unstable resting potential is because of HCN channels which cause the slow influx of sodium ions without any compensating efflux of potassium ions. And so that is the reason for this gradual increase in membrane potential to reach the threshold. So we see the cells will continuously keep depolarizing, and the threshold for the action potential will be reached, all because of these funny channels. And we have described it as I subscript F. Right? We can also call this as HCN channels. So now I want to point out the 2 types of action potentials which we will see in the cardiac muscle. You have this action potential due to the autorhythmic cells versus the action potential in the contractile cells. And notice how the shape of these action potentials are different. And I want to just refresh your memory and talk you through what are the various steps involved in this first action potential versus the second one. Keep in mind that it is these action potentials of the autorhythmic cells which will cause these contractile cells to reach the threshold of the membrane potential, and that triggers this action potential of the contractile cells. So let's start with the autonomic cells. You see that the HCN channels will spontaneously depolarize to reach the threshold, and once the threshold is reached, what channels are opened? Voltage-gated calcium channels, right? Just opening of voltage-gated calcium channels, and so calcium will flow into these cells, causing a rapid depolarization. And this rapid depolarization will cause the opening of voltage-gated potassium channels, and potassium will flow out of the cell, causing a rapid repolarization, bringing it back to the resting membrane potential. But also, this repolarization will cause the activation of the HCN channels. Now, this action potential will be passed on through the gap junctions to these contractile cells. So it goes from one contractile cell to the other through gap junctions. And once the threshold is reached in the contractile cells, we see the opening of the voltage-gated sodium channels will cause this rapid depolarization in the membrane potential, and that is followed by the plateau phase, because you have calcium coming in and it is going to offset the potassium ions leaving out. That's why there's this plateau phase. Keep in mind that this calcium which is entering into the contractile cells, that will cause the sarcoplasmic reticulum to release more calcium. So that is the calcium-induced calcium release unique to the cardiac myocytes. And eventually these calcium channels will close, and then there can be rapid repolarization because the potassium ions will flow out due to the fact that there's no more calcium ions leaving the cells, right? So there can be a rapid repolarization of the membrane potential to the resting membrane potential. Are we clear on this? What are the various steps involved in the different kinds of action potential? Here's a great question can be written on this, right? Just what channel causes which phase in the autorhythmic cell versus the contractile cell. So think about that perspective and make sure you know the various steps. So when we come back to the conduction system, we see that the sino-arterial node, or the SA node, is capable of firing around 75 action potentials per minute, right? So it's the fastest rate of action potentials being generated in the conduction system. In contrast to that, the atrioventricular node will have only 50 action potentials fired per minute. Now the reason for this difference is that the number of HCM channels which are expressed in the sino-arterial node is going to be much higher, right, than the atrioventricular node, and that is why it can fire these action potentials at a much faster rate. Is that clear? Why the SA node has a higher frequency of firing action potentials compared to the AV node? It's because of the number of HCM channels expressed. And once the action potentials reach the AV node, there is not a 50 millisecond delay, but there's actually a 100 millisecond delay. And the reason for this delay is the presence of the cardiac skeleton, which I mentioned to you yesterday. So the cardiac skeleton is made of connective tissue. You can have electrical current passing through it. And so we find that the action potentials can only pass through this AV bundle down to the Purkinje fibers. Now if this cardiac skeleton was not dividing the atria and the ventricles, then we see that the atrial cells could pass on their action potentials to the ventricular cells. But they can't do that. We have to pass it only through this conduction system because of the presence of the cardiac skeleton. And when you notice the bundle branches, they're going to fire these action potentials at even a slower pace, again because of the fewer number of HCN channels. And we find that the depolarization of the ventricles will start from the apex of the ventricle down to its base because of the conduction system and the presence of the cardiac skeleton. So it's going to go all the way down and then move upward and then it will contract. Are there any questions before we proceed? Alright. So with that we move on to the second topic, and that is the ECG or the or EKG, electrocardiography. And so this is going to be the transthoracic interpretation of the electrical activity of the heart over time, right? So we see that this activity of the heart will be seen with respect to time. So on the x-axis you will have time, and if this activity is not going to follow a specific pattern in respect to time, that can lead to problems. And there will be electrodes or leads placed on various parts of the body, and this is a non-invasive technique because these electrodes can be placed externally, and the output recording is what is known as the electrocardiogram. Now the electrocardiogram is a composite of all the action potentials generated by the myocardium as a whole. It's not referring only to the action potentials generated by the autorhythmic cells, but the entire myocardium's action potentials as a composite is expressed in this electrocardiogram. And we'll see that there can be abnormalities which are detected depending on changes in the electrocardiogram. So in order to appreciate what are these abnormalities, we need to understand what are the different parts of the electrocardiogram and what they are referring to. So if you look at this picture here, you'll notice there's a P wave followed by a QRS complex, which is much larger, and then you have the T wave. Right? I noticed that even if you were to watch some TV programs, you'll see the electrocardiogram readings going on. And if you didn't know how to interpret it, you can probably tell your family and friends that now you know what it is referring to. Right? So we find that the sinoarterial node is going to fire at the start of the P wave. And here's a picture showing you where the sinoarterial node is, and once it fires, the action potentials are going to travel through the atria, and also it will start traveling down through the internodal pathways. And we find that once the sinoarterial node fires, it will cause the atria to start depolarizing. And what we mean by depolarizing is the inside of the cell is becoming less negative, thereby causing the threshold to be reached. And so eventually, after the atria depolarizes, it's going to contract. And we notice that from the P wave to the QRS complex, there is this PR segment. So the R is referring to this high part of the wave here, and it's called the PR segment, and that's going to be around 100 millisecond delay. And the reason for that delay is that the cardiac skeleton is preventing the action potentials from passing right through. They have to pass through the AV node and through the bundle of His. And once the action potential reaches the AV node, we find that it's going to travel down the intraventricular septum, and it traveling down the intraventricular septum is depicted by this Q wave here. And then this entire QRS complex is denoting the whole ventricle depolarizing and contracting. Now, while this QRS complex is indicating the ventricular depolarization, simultaneously the atria is repolarizing. By that time, the atria has already finished its contraction and it is relaxing, and the repolarization is taking place. That's what is happening to the QRS complex. And the phase shown here, the ST segment, it's indicating the plateau phase in the action potential of the cardiac myocytes. So remember the plateau phase I showed you. You have a rapid depolarization, plateau phase, and then repolarization. That is what is indicated by this ST segment. And this T wave is indicating when the ventricle is repolarizing, and as a result it's going to relax, and the entire ventricle depolarization and repolarization is shown by this QT interval. And the distance between two R waves is going to be one heartbeat. And if you have a shorter distance between the R waves, it means the heartbeat is going pretty fast. But the greater the distance between the R waves, it means the heartbeat is getting slower. So now let's walk through the different parts of the EKG readings and how it corresponds to the electrical activity of the heart. So notice here that this red line here is indicating that the sinoarterial node is about to fire, and it's going to cause the atria to eventually contract. And when you see this P wave shown here in red, it means that the atria has depolarized, and as a result it's going to contract, and the signals are reaching the atrioventricular node. And this short distance here between the P wave and the QRS complex shown here in red, that is indicating the delay at the AV node due to the cardiac skeleton. And this Q wave shown here in red is indicating the interventricular septum getting depolarized. Now this action potential, as it travels down the interventricular septum, it's going to move into the ventricles through the Purkinje fibers. But I also want to point out that not only the ventricles contract, but also the papillary muscles, which I told you about yesterday, they also contract. And the way these papillary muscles contract is that there is a band known as the moderator band, which will carry the action potentials into the right ventricle, and thereby it will cause the papillary muscles in the right ventricle to contract as well. And finally, notice that this QRS complex is indicating the depolarization of the ventricles and also the repolarization of the atria. This is already finished contracting and now it is relaxing. So this is just showing you the various steps of the movement of the action potentials through the conduction system of the heart. So there are a lot of details here, but if you want to start to understand all of this, I will tell you to start by looking at three things, right? So the first thing I want you to consider is that the P wave is going to indicate the atrial depolarization, which means following the P wave, the atria will contract. That's the first thing, right? Second thing is that the QRS complex is going to indicate the ventricles depolarizing, and as a result of the QRS complex, the ventricles will contract. And the third thing I want to point out is that the T wave is indicating the ventricles repolarizing, and as a result they are going to relax after the T wave. So start with these three steps, and then once you get this foundation down, you can add on the additional details of what the various segments and time intervals mean. So now let's talk about what are some of the things which can go wrong and which can be detected using the EKG readings. So the first one is a condition known as bradycardia, where you have a really slow heart rhythm, and this can be indicated by a longer distance between the R waves. So the QRS complex, you notice the R wave is the highest part of the QRS complex. The longer the distance, it means bradycardia because the heart rate has slowed down. On the other hand, tachycardia is where you have a fast heart rhythm, and you find the distance between the R waves are decreased. Heart blocks are something which can also be detected using the ECG readings, and this is referring to the interruptions in the normal conduction pathway, right? So the conduction pathway, I told you, is going to start with the sinoatrial node and travel down the internodal pathways down to the AV node. And so if there is a interruption in this conduction pathway, that will lead to a heart block, and that can be detected. Now there are three types of heart block. You have a first degree, second degree, third degree, and on the upper panel, the normal ECG readings are shown. And a first degree heart block is when you have a delay between the conduction of the signals from the SA node down to the AV node, right? And if there is a delay, that will be indicated by a longer PR interval. So the distance between the P wave and the QRS complex is going to be slightly long. So if you compare this region shown here in the red circle with the above P wave and the QRS complex, we see that the distance is slightly larger. It may not look like a big deal, but that is showing that there is a block, there's a first degree block, and there's a delay in the signals reaching from the SA node to the AB node. Is this clear, folks, what we mean by a first degree block? I only saw one thumbs up. I want 2 more thumbs up. Alright, cool. Alright, thank you. I got 4. Great. So, now let's move to a second degree block. Now, the second degree block, we see that only some impulses are reaching from the SA node down to the atrioventricular node. Okay? And as a result of that, in some cases, you will not have the QRS complex, which should follow the P wave. So, notice here, you have the P wave, following that you have the QRS complex, and notice here there is a QRS complex missing. Even though there is a P wave here, the QRS complex is missing. Now, in this case it is missing, in this case it is just fine. In the previous case also it is just fine. So, only in some cases are the signals passing through. So, a few QRS complexes dropping out of the ECG reading can indicate a second degree block. Are we clear? First degree block, there's a delay between P and QRS, P wave and QRS complex. Here you have a few QRS complex missing. Now a third degree block is where you have no correlation between the atrial and ventricular activity. What I mean by no correlation between atrial and ventricular activity is that you will not have the P waves followed by the QRS complexes at a greater degree. So it is similar to a second degree heart block, but you find that in this case there is 2 P waves, no QRS complex at all. So there seems to be no correlation between the activity at the SA node and the corresponding QRS complex. So those are the types of heart blocks. And you can also determine fibrillation of the atria and the ventricles. And fibrillation is referring to the rapid, irregular, out of phase contractions. So it is rapid, irregular, and out of phase. And when it is all these three, the pressure generated by the heart cannot be used for pumping out blood. So let's look at 2 types of fibrillation. So in this atrial fibrillation, you notice that the QRS complexes are not affected. They seem to be coming just fine, but you don't find the P waves followed by that by the PR segment delay. Right? So this is an example of atrial fibrillation. In the case of ventricular fibrillation, notice there are no QRS complexes at all. You don't see any indication of the ventricle depolarization and the consequent contraction of the ventricles. So this is an example of ventricular defibrillation. So is this clear how some of the problems in the conduction pathway can be detected using the ECG readings? Okay, the good news is I'm not going to give you ECG reading in the exam and tell you to determine what the problem is. Right? This is just to give you an example of what can potentially go wrong. And I'll tell you the reason why I won't give you a ECG reading, right? Even if some of you are really eager to interpret it. Keep in mind that in order to interpret these readings, you would need many years of training as a cardiologist. Right? And let me give you a few examples of other abnormalities which can be determined using the ECG readings. So sometimes you can have an amplified P wave, which could be indicative of the atria being enlarged. So it's having a larger amount of electrical activity because it is enlarged. And then you could also have a flatter T wave, which may be indicative of insufficient oxygen being delivered to the myocardium. So it is in the T wave where you have the ventricles relaxing. And if that's flatter, it seems to indicate that less oxygen is reaching the myocardium. And if you have less oxygen reaching the myocardium, it will eventually lead to myocardial infarction, where the cardiac tissue will die. And sometimes you have this type of elevation in the ST segment shown here, and that could be indicative of acute myocardial infarction. Right? So this is what that looks like. And there are also some limitations using the ECG. Right? For example, there may be some pulseless electrical activity. So even though electrical activity shows on the ECG, there would not be a corresponding pumping action. So just because there's electrical activity showing up on the ECG doesn't mean that the ventricles are going to pump in accordance. And not all areas which are affected by the myocardial infarction would show up on a ECG as well. So there are some limitations, and that's why there are other kinds of diagnostic tools like echocardiogram, which can be used to identify pathologies. But I just give you the examples to tell you that interpreting ECG readings is complicated, and I hope you can interpret at least what is happening in a normal ECG reading. You know, what does the P wave stand for? What does the QRS complex stand for? What does the T wave stand for? And so on. Does you have a question?
I was just wondering if you know of anything where they overlap the pulse with the echocardiogram, just because that seems based on what you've been explaining, both in terms of this more complex version of the ECG, as well as the more basic things. It would be very useful to compare those two values. Do you know if there are anything?
Not that I know of, but I'm sure that's how they would do it. You know, in order to identify a problem, you'd use different diagnostic methods to see what they're saying. Yeah. Okay, so now let's talk about two common terms. You've heard about the term cardiac arrest and heart attack, and it's easy to get confused between these two, right? But hopefully after the next 2 minutes of what I have to tell you, you will be so clear on the difference between a heart attack and a cardiac arrest. So cardiac arrest is an electrical problem, right? When you have abnormalities in this electrical activity of the heart, that is known as a cardiac arrest, and this is pretty lethal because the fatality can be very quick. If the electrical activity isn't reset immediately, within a few minutes, the person will die. So that is the cardiac arrest. Now, a heart attack is referring to where you have the blood vessels being blocked due to atherosclerosis, and this can happen gradually over time, right? And if the longer you take to fix this problem, it can lead to more death of the cardiac tissue, because the less blood is being supplied, less it gets oxygenated, and eventually those tissues can die. So the heart attack is going to be a tubing problem, whereas the cardiac arrest is going to be an electrical problem. So we see that one is happening very instantly, the other one happens slowly, and so the two things I imagine which help me to keep it straight is that when I think about the word arrest, I'm reminded of the game Monopoly. How many of you have played Monopoly? Ah, fantastic. Good. So you guys know about the go to jail card, right? The moment you pick the card, you stop losing, you lose your turn, you gotta be in jail until you eventually get out, right? So it's going to have a very immediate effect. So cardiac arrest has an immediate effect because it's affecting the electrical activity of the heart. Now, when I think about an attack, right? Have any of you played like strategy games? Age of Empires. I used to play it a long time ago and realized the real time waste. Now I waste my time in other ways. But whenever you have an attack of a castle, you know, it's under siege, it's not going to follow immediately, right? It takes a while for the siege weapons to attack the castle, and then they have battering rams and people trying to break down the walls. So it takes time, right? So this heart attack takes a long time to take place, whereas a cardiac arrest happens pretty quickly. So the disclaimer I want to make is that going to jail or being under siege during time of war is not something trivial, right? I'm not making fun of those serious things, but it does help me to keep these two pathological conditions straight in my head, and if it helps you, please use it, but if not, forget what I said and forgive me too, right? Okay, now we move on to the various steps involved in the cardiac cycle, right? So the way we are going to do this is kind of like reading music sheet. Start with the treble clef, go down to the bass clef, go back again. So that's how we're going to start with the upper panel. You look at the electrocardiogram, right? Then we'll see what are the corresponding changes in pressure, and then we'll move down to how does it affect the volume of blood in the heart, and then we'll gradually move back to again what's happening in the electrocardiogram, and then we'll come down to the pressure, and then back to the blood volume. So we'll be going back and forth. Now I told you that the most challenging part of this picture here is the changes in pressure. All right. So whenever we talk about the middle panel, right, changes in pressure, you could ask one of three questions. All right. And so the first question you ask is, why does the atrioventricular valve open? And this whole question is written in blue because I want you to write it out. The first question is, why does the AV valve open? This could be the right AV valve or the left AV valve. Ask yourself that first question. The second question you ask is, why are both the AV valve and the aortic valve closed? Right? It could be the aortic or the pulmonary valve. But the question is, why is both the atrioventricular valve and the aortic valve closed? The third question you could ask yourself is, why does the aortic valve open? You got those three questions down? Why is the AV valve open? And why does the aortic valve open? And why would both valves be closed? Right. Now the short answer for this is differences in pressure. Right. That's why I told you that these three questions are relevant to this middle panel. And let me just quickly walk you through this. So the only reason the AV valve is going to be open is that the pressure in the atria is going to be higher than the pressure in the ventricle. Are we set? That the only reason the AV valve will open is the atrial pressure is going to be higher than the ventricular pressure. Sounds good? And if you look at this, this picture here, it shows that the atrial pressure is shown in blue, ventricular pressure is shown in red. So when the blue line is below the red line, the AV valve is open. Now, the time when both valves are closed is that the ventricular pressure is going to be higher than the atrial pressure, but lower than the aortic valve pressure. I repeat that again. The only time both valves are closed is because the ventricular pressure is going to be in between the aortic pressure, the atrial pressure and the aortic pressure. So ventricular pressure has to be higher than the atrial pressure as shown here. See, it is higher, the red line is higher than the blue line, but it is below the black line. So that's when both valves will be closed. And the third answer, why is the aortic valve open, is because the ventricular pressure is topped out, right? It's higher than both the aortic pressure and the atrial pressure. That is the reason why the third situation would be true. The third one is, why is the aortic valve open? The aortic valve is open because the ventricular pressure, so this is a part where the aortic valve is open. The ventricular pressure is going to be higher than the aortic pressure, and it's also higher than the atrial pressure. So keep these three things in mind as we go through the next 8 steps. You have one slide showing you all the 8 steps. I'll divide that up into 8 slides, and let's walk through it step by step. Okay, so step 1, it says the atrial contraction begins, and it's going to be the initial part of the T wave. And notice that it says down here it's going to be the beginning of the atrial systole. So the term systole and diastole, let me explain. Systole is referring to the contraction of the muscle, diastole is referring to the relaxation. So you have the atrial systole where the atria contracts, atrial diastole where it relaxes, ventricular systole when the ventricle contracts, ventricular diastoles when it relaxes. So when you look at this first part here, notice that the atrial pressure is higher than the ventricular pressure. The blue line is above the red line. And there's something really interesting. I want you to notice that as a result of the blue line being above the red line, the AV valve is open and blood can flow from the atria into the ventricle down the pressure gradient. Are we clear on that? Because the atrial pressure is higher than ventricular pressure, the mitral valve is open and blood can flow in passively. And because of blood flowing in passively, notice that the volume here, the volume of blood in the ventricle is almost to full level, right? So it would have initially been here, but the volume is almost to full level at step 1. Are we clear here, folks? The atria is about to start contracting. It's the beginning of the P wave, but most of the ventricle is already filled with blood because of passive reasons. The atrial pressure is higher than the ventricular pressure. Can we move to step 2? Okay, step 2. We have the atrial systole, right? Because the P wave has happened, the atria has depolarized, the atria has contracted, right? And notice in the second panel, the aortic pressure is still way up there. And even down here, the atrial pressure is slightly higher than the ventricular pressure. But notice that there's a sudden bump in the atrial pressure, right? That's because the atria is contracting. And so you notice that there's going to be a sudden increase in the ventricular volume because the atria contracts and it squeezes out the last bit of blood in it into the ventricle. So you see that it goes from almost being full to, it's now from almost being full to full because of the atrial contraction. This is step 2. Are we clear on this? Move to step 3. Yes.
So just a clarification, in step 1, it's based on passive transfer and kind of
from the atria to the ventricles. Yeah.
Is it from gravity? And
it's the pressure differences, not gravity, because you could be upside down and still you will have the passive filling.
Okay, but it's just like a small pressure difference that's causing it
Yeah.
to flow. Oh, and then it squeezes.
That happens in step 2. The
Right,
squeezing.
that's step 2. It
Correct.
squeezes to get everything out.
Everything
which
in.
then also causes a pressure dip, which will then get into step 3, right?
No, step 3 I'll get to it in a second. So you have it right. Step 1 and 2 you have it right.
Okay.
So first step is due to passive filling. Step 2 is due to active filling because the atria contracts. Okay, let's move on to step 3. So notice that step 3 is showing you the QRS complex, and the QRS complex is where you have the ventricular depolarization, right? So the ventricle is going to contract, and in the meanwhile, notice that the atria is going to relax. So it's the end of the atrial systole and the atrial diastole is starting in the QRS complex. And at this point, notice that the blue line here, right, is no longer above the red line. So the atrial pressure is no longer higher than the ventricular pressure because the ventricle has started depolarizing and starting to contract, right? But the thing to notice here is that the ventricular pressure may be higher than the atrial pressure, but it's still below the aortic pressure, and so both the aortic valve and the AV valve are both closed. And when both those valves are closed, there won't be any change in volume inside the ventricle, and that's why you see this flat line here. Right? Are we clear why there's a flat line? Both valves are closed, no change in volume. And then in step 4, we call this the isovolumic contraction because both valves are closed, no change in volume, but the ventricle is still contracting and producing force because of the previous step which caused the ventricular depolarization. So this isovolumic contraction, and following this we find the ejection phase where the ventricular pressure finally overcomes the pressure of the aortic valve, and that causes the blood to flow to the aorta, right? And so this is the ejection phase, and this ejection phase is going to happen between the QRS complex and the T wave. And blood is being ejected, notice in the final panel down here, the third panel, the volume of blood in the ventricle is dramatically decreasing. Right? So it was at this place, but as blood is being ejected out, the volume is gradually decreasing. So this is step 5. Are we clear? All right. And so notice that during the ejection phase, you have the T wave also happening, which means the ventricle will now start repolarizing, and thereby it starts the ventricular diastole, shown right here. And during the ventricular diastole, notice that at some point the ventricular pressure finally drops below the aortic pressure. When it drops below the aortic pressure, the aortic valve will close, and also because the ventricular pressure is higher than the atrial pressure, the AV valve is also closed. Right? So both valves are closed, so there is no change in volume at this point, and that will lead to the isovolumic relaxation of the ventricles. And from the isovolumic relaxation of the ventricles, we see that the ventricular pressure is going to eventually drop below the atrial pressure. Notice the red line is below the blue line, and so the mitral valve opens, the atrioventricular valve opens, and then you have the passive filling of blood, right, from the atria into the ventricles. So that is the cardiovascular cycle. We have 3 minutes, and yeah, let's do the PV. Let's do the PV loop on Monday, right? The pressure volume loop, because your mind is already probably fried. But you will see how both the panel 2 and 3, how they will eventually fit into this pressure volume loop, right? So we'll talk about that on Monday. Have a fantastic weekend, everybody, and again, good night.